Welcome everybody to another PsyTech webinar. We're very, very happy to have you all here again joining us. We are always grateful for when you join a PsyTech webinar. And today's topic is really fascinating with an incredible panel. It's the topic, as you know, is ketamine delivery, patient success and ethics, how to ensure the best outcome for your patients. And we know this is a very important topic, especially as more clinics keep opening. I'm going to jump right in introducing our moderator, Manish Gurn. He's the Chief Research Officer at the psychedelic bioscience company Entheotech Bioscience, and also runs a YouTube channel called The Psychedelic Scientist, which sounds really interesting. He's also in the latter stages of attaining his PhD at McGill University, I believe, Manish, correct? Manish, I'm going to hand this over to you to introduce all of our wonderful panelists, and I'll leave it with you. Thank you.
Yep, awesome. Thanks, Deb. Yeah, to get us started, I'm joined by an awesome team of panelists here. So I'm going to walk through some bios for each of them. And then I'll give each of you a chance to say anything I missed or anything else you want to say about yourself. To start off, I'm going to introduce Dr. Pam Crisco. She's a medical doctor with a strong interest in chronic pain, mental health, and psychedelic medicine. She's a clinical instructor at the University of British Columbia in Canada, and an adjunct professor at Vancouver Island University, as well as one of the founding board members of the Psychedelic Association of Canada. She's also the medical lead on the Roots to Thrive ketamine-assisted therapy program that treats healthcare providers who are suffering from PTSD, depression, anxiety, or addiction. And next on the panel is Dr. Abid Nazir. He's a board-certified psychiatrist and is the founder and president of Advanced Psychiatric Solutions / APS Ketamine, which he established in 2016 as the first psychiatric outpatient ketamine clinic in Illinois. His practice was actually recently acquired by Wasana Health, a company for which he is now chief medical officer. Among his various other roles, Dr. Nazir is providing medical oversight to the growth plans of Wasana clinics with the model of comprehensive psychiatric clinics specialized in ketamine and psychedelic therapies, among other things. And then lastly on our panel is Dr. Reid Robison. He's also a board certified psychiatrist, and he's currently a chief medical officer at Novamind. He was among the first clinicians to prescribe ketamine off-label for the treatment of depression in Utah. And in 2011, he obtained his first grant to study ketamine and developed the ketamine depression protocols for the Intermountain Medical Center, which is Utah's largest hospital. And then in 2012, Dr. Robinson led the Utah site for the intranasal S-ketamine study for treatment-resistant depression by Janssen, which led eventually to the FDA approval of Spravato. And he currently supervises and trains ketamine-assisted psychotherapy practitioners in Utah, and to date has guided thousands of ketamine therapy journeys and hundreds of Spravato dosing sessions. So that's what I have for intros for all you three. So maybe just one by one in the order that I introduced you, if you have any other words to say about yourself for introduction.
Thanks. You pretty much covered it. The only thing that's new to that is I'm also the medical co-chair of the a program that's launching in Canada here at Vancouver Island University, the postgraduate certificate in psychedelic assisted therapies, which will be the first academic program in Canada launching, teaching professionals.
Amazing. Thank you.
All right. Thank you. I'm happy to be here. Excited for the talk. You covered most everything for me too. Just the latest edition is just as Vice President for American Association of Psychedelics, which is just launching now this year. So excited for that, and a conference we're putting on in November in Tennessee. But otherwise, my other specialty is addiction medicine and psychiatry, and I think the rest of it you got covered right now as Chief Medical Officer for Wasana.
Nothing really to add from my end. I'll just echo the, we train CAP practitioners as well, and believe that training is as a form of advocacy for accessibility, how to open this up in a good way. Looking forward to the discussion.
Awesome. Cool. Thank you. Yeah, we'll jump right in. There's a lot of interesting things we can cover today. So to start us off, just by way of introduction, I mean, it seems to me in the ketamine space in terms of clinics, there's this there's two main approaches you could say are that ketamine is administered within. So one is seeing ketamine as like a standalone pharmacological treatment which works via neurobiological mechanisms and for which the experience it induces is kind of an unwanted side effect. So that's kind of the medical approach to ketamine that's being kind of standard in a lot of clinics, especially in the US, as far as I know. And then the other side of this is seeing ketamine as a psychedelic and administering it in a psychedelic-assisted psychotherapy framework similar to psilocybin. And then within that framework is highlighting the role of non-pharmacological factors, so context, therapeutic alliance, psychotherapeutic support, and all these things outside of the drug experience, and then also focusing on the experience itself. So there's these two widely divergent ways of administering ketamine that are out there. So the question I want to start off with is, how do you think ketamine should be best delivered to patients? And to start us off, maybe I'll direct it towards you, Abid.
Sure. I mean, that's both approaches. I think they have their own place. I mean, it's pretty clear that psychotherapy has to have some component in this. But are there patients who might be able to be administered ketamine in whatever formulation or route or setting and still get improvement without officially having ketamine-assisted psychotherapy kind of approach? Yeah, there are many. There's many where the dissociation causes a lot of anxiety. They view it as a side effect and it's a barrier to treatment. So there are ways to obviously adjust how we give ketamine. Let's say if it's IV form, we slow the drip down, we would lower the dose, extend the infusion time, and that makes it a little less intense, and we'll still see improvements. But the psychotherapy should still be there if it's not as official cap with preparation, integration, and then especially during the dosing session, there should still be some element of psychotherapy in between to maximize the neuroplastic state you're in. If we kind of ignore all of that, even if we're administering it just as a standalone medication, I mean, many times you might get some improvement, but a lot of times we'll see that improvement not be to the point where we want it, or we'll see old behavioral or thought patterns kind of sabotage some of the progress. I mean, when somebody goes through that kind of a change in their outlook, in their symptom relief, their role identity changes, there has to be some support with it. So I think the best model is with psychotherapy, but there are ways. I think there are some patients where to get them involved, it might not be a extremely dissociative experience that you're chasing. You're hoping for that, the neurochemistry benefits part of this, not the experiential part. But then you got to support that in a 360 continuum outside of that dosing session.
Thank you. Yeah, and Pam and Reed, either of you want to add to that?
Yeah, I'll jump in. I think a lot of great points there. I agree with all of them. And I think there's a lot of different ways to approach this. We're all going to be biased in favor of the way that we've seen works the best. And so that bias is fine. And so if that's your bias, do it really, really well. Do good intake, do good, set and setting treatment. If your bias is to give IV in a busy ER setting for suicidality, then optimize everything you can. Get them in a quiet room. Can you get a social worker at the bedside to do some talk therapy after? That's reality is ketamine is a phenomenally versatile medication. And what we want to do is, however we're deciding to use it, however people are using it, do it at the best level. I'm biased towards group therapy because that's what we do and that's what we see that works. And I know that experts in other areas that do one-on-one or dyad work are IV. As long as you're doing it at the best level, I think that is always what we should be asking ourselves. Are we doing this at the best level? Are we constantly seeking quality improvement from the patients we serve? Are we listening to them and hearing what they need? And are we doing patient-oriented, improvements? So,
I really appreciate those comments of checking our biases, being open to continually learning about this. And I'll just point out one way that, a couple thoughts. What we've landed on is leaning towards accessibility, both in the group format, but also in an individual session, but with shared monitoring. Like down the hall for me in one of our clinics is a typical ketamine room set up with a nurse's station where you have a clinician, an MA or nurse, and then 4 ketamine bays with glass front. And then we'll use any form of delivery. It could be IM, it could be intranasal S-ketamine, it could be IV. And someone might be in there doing psychotherapy the whole time, or it might be just the beginning and end, but we can leverage the economies of scale there, in addition to having individual private CAP sessions in private rooms. But the other thing to point out, I think, is I like to look at it as 3 different ways of working with ketamine. We've got kind of the psychedelic or the CAP route on one end, which is, say, IM, eye shades, headphones, therapist, and then kind of on the other end of the spectrum is psychiatric, like S-ketamine for TRD, approved by insurance, without any therapy approval as part of that. Of course, we always want therapy going on, or ketamine for someone in crisis as a rapid antidepressant. And then kind of as a third bucket, I'd say psycholytic. We'll do lozenge or intranasal ketamine in either individual or group format in therapy sometimes.
Yes, thank you. Abid, do you want to say something?
Yeah, I think just to piggyback up what they're saying, I think one really important part of all of what's the best way to, I agree we should be agnostic to like the ketamine approach. Like we should do what we do, really focus on doing it well. But what is well, and to me, it's important that if it's being administered, the setting, like it should have, there needs to be some element of expertise there to handle psychiatric emergencies, manage patient expectations. There needs to be some element of a comprehensive care approach. So let's say ketamine's not working for somebody and their suicidal ideations increase afterward because there's a sense of helplessness or hopelessness. If it's somebody administering it all alone in a bubble and they don't really have any support or that expertise, and no follow-up or follow-through, that to me is not at all a good way to administer it. So if somebody's administering it and they're not in the psychiatric field, they need to make sure there's some psychiatric support with it.
Great, thank you. Yeah. So what I'm hearing is like it's very individual specific. There's no blanket statement we can make, and it's just a matter of doing the best with what's available for that particular patient and within the resources of the clinic that you're situated, which very much makes sense. So another thing that came to me is kind of in terms of conceptualizing ketamine's efficacy and its effects. One way of seeing it, because we know that ketamine, if you use an IV model, typically the symptom reductions last a couple of weeks, maybe, and they trail off quite quick. And I'm wondering, in terms of seeing ketamine as this treatment you'll likely have to take indefinitely, and it's a way of like palliating symptoms in a temporary way, versus actually modifying the course of their, mental health, their illness or disease, if you want to call it that, and actually making it such that they won't need ketamine for a certain point. They won't need another treatment. This seems like 2 very different approaches to how ketamine can be given. Can any of you speak to that and how that's situated within this discussion?
I'm happy to jump in and start with this. I think this speaks really to patient selection and what each patient needs. And again, patient-oriented intakes. I think in our program, the Roots to Thrive program, it's a 12-week resiliency program with 3 ketamine-assisted therapy sessions within the program. And then we have an alumni program where people can continue to get ketamine or even just the group therapy if they're needed. Now we see people come through our 12-week program and at, after 1 ketamine session, like they're like, I'm awesome. This is great. And then there's other people that it's the 3. And then there's people that move into our alumni and they need 7, 8 to 12, whatever. And it's different. And so again, this is the patient-oriented quality improvement, is that we listen to what the patients need and make sure that we can provide that with the full wraparound, because maybe after the 2nd ketamine session, they don't need any more ketamine. They need to learn how to eat better. They need to learn to get back into exercising. Now they're back out in nature and now they're reconnecting with their family. So our approach is the whole person, is that ketamine is only a tool in that toolbox. But if they're not eating well, if they're not connecting, if they're not in community, if they're not, all the other things that make us humans, if that's not part of it, then the ketamine can only do so much. So we'll say the ketamine will show up, and then how are you going to show up? How are we going to show up as a team? And so we do a full wraparound, which speaks to Abid's, sorry if I'm getting your name wrong. Your point is that competency of knowing, like, are you holding that patient really, really well? And I think that's probably part of the fundamental conversation we all need to have is, how do we know if we're good? How do we know if we're doing no harm, right? Like, how do we as professionals have some sort of feedback loop to make sure we're not losing people? Because that's what we're seeing in our program. We're seeing people that have, gone through some of the IV ketamine clinics and have been cut loose, and they're loose. And so we grab them and scoop them up with a full team wraparound. And so that's just something I'd really ask people out there that are doing it is, how do you know if you're any good? What are your feedback loops to how you're taking care of your patients?
Totally. Thank you. Reid, Abid, anything you wanted to add to this?
I can just add a little comment about, using real world data to learn as we go, because this is a new and emerging field we're in, or discipline, and we don't have all the answers. Yes, there's a much needed explosion in the number of research articles coming out that helps shine a light on some of the parts of this. But one thing we'll do is regularly, query our records as well, looking for outcomes. How do people do on IV versus IM? How did this group 6-week program do? And use rating scales, outcome measures as much as possible to have both have some more objective data to look at as we go as well, for continual quality improvement, or I guess not just evidence-based practices, but practice-based evidence, just this feedback loop.
Definitely.
Yeah, I agree with that. I think it's important to look at that patient's kind of bad past treatment history and really set expectations from the beginning. Somebody has really, they've been through ECT, TMS, multiple rounds of psychotherapy, genetic testing, all the meds have been tried, and they're in front of you now for ketamine treatment. Yeah, it's most likely going to need maintenance, ongoing maintenance, but the goal should be the least amount possible. So our barometer is, once somebody's in a maintenance phase, if their maintenance interval is shortening, so we're seeing it actually, they're coming in more frequently, then we usually, that triggers an intervention on our part to say, okay, what else outside of ketamine needs to happen to get them to a point where they don't need to come in as often. If somebody comes in with acute suicidality, but very limited treatment history, I usually set that expectation right away that we'll do this temporarily, but let's at the same time try all the other traditional methods that we have available in conjunction with it, whether it be IOP programs, psychotherapy, or genetic testing and med optimization. But the goal will be that you'll be doing well in maintenance from ketamine while we're instituting some other measures, and then you can graduate off of it. So I think every patient's very different, but I don't think it's right to tell a patient automatically you will be coming in monthly for treatments, or you'll be coming every 2 weeks. I think all our data is being mined right now, and it should be here hopefully next week, where I'll actually get a little bit more statistical knowledge on what is our clinic's exact average maintenance, treatment frequency. And what I can see, it seems to be longer than 2 weeks, and I think it's probably more like 6 weeks. And I think that has a lot to do with providing wraparound services, like Pam was alluding to. That's important.
Totally. And Reid, did you have something?
No, nothing else to add for now.
Okay, great.
I would like to just add one more thing to this that I think is really important for all of us people that are doing this, is really figure out what you're really good at. Where's your niche? Like, who do you really, really help, and work with them. We can't be all things to all people. Our program has again, we're constantly in quality improvement, and we're realizing what patients we can't hold, what patients we don't have the skill set to do, and then helping them get resourced with other colleagues that are out there that can have a much better skill set in that specific area. And I think that's really important. I think you want to really be discerning, going, where is your excellence? What can you do well? And then letting your colleagues pick up in their slice where they do really, really well. That's the best thing we can do. And ultimately, if we're all thinking, how can we put ourselves out of business? How can our patients do so well they don't need us? Then we're going to do that really well. And I think there's more than enough mental health challenges in this world for everyone, that you don't have to be all to everything.
Mm-hmm. Yes, thank you. This has been great. Yeah, very much agree that the holistic kind of context of the treatment is so important. And it goes to what I said before, like, sometimes it's conceptualized as a standalone, but you just can't do that with something like ketamine, which induces these kinds of experiences. And so important to acknowledge that humans are complex and there's so many factors in somebody's life that contribute to their illness. You can't just think changing their brain is going to change their mental illness in the long term. There's a whole variety of social and economic factors which play a role. So totally. So one question before we move on to slightly a different topic, I want to ask this question because it's a very interesting one, and one that often comes up, and I think is increasingly explored in the research, is in the patients who take let's say a higher dose of ketamine IV or whatever route, and they have a strong associative effect, as you might call it, or a psychedelic effect, as some might say it. Do you think the content of the experience itself plays a role in the treatment, and it can be a source of psychological insight? Do you think there's a relationship between the individual specific content that emerges and their outcomes? And how about Pam? I feel like you might have a strong opinion there.
Well, I have a lot of opinions, not all right. We're kind of actually, again, I think this is really where it's really fun to be observational scientists and watch what's happening. And what I'm really noticing or what our team has been noticing for the last while, and we're shifting a little bit because of this, is that there's so much focus on the experience. And did I see rainbows? Did I meet God? Did I have universal love? Like, did I have the mystical experience? All that stuff. There's so much emphasis on that often, and we stopped doing the MEQ because if people didn't have that, they felt that their experience was less than. And so we're moving away from that. And like, there's so much in the media about what it should be, what your experience should be. Now, we coach them very strongly all through this, that your experience is unique. You are unique. Your life is unique. Your experience will be unique. And really working now on them to say, look, that experience was interesting. And now, who are you now? Like, that is our paramount question. Who are you now? Who are you now? And what is next? Right? And what do you came into the ketamine session as a person, you have now had some insights and experience. And now what? That's the integration part of it. What are we going to do with that? What are you going to do with it? What have you shed? You don't have to go back. It's like, the analogy I use all the time with my patients is, you've just gone for a haircut. There's hair on the floor. You're not going to get down on the floor and go, what's going to happen to the hair? No, you get on with your life. You just go forward and go, who am I now with that? And so I think we need to disambiguate that, say, okay, the experience has happened. Now what? Now, what are you doing? Who are you now? What are the changes you're going to make? What resources do you need? And so, and then I'm sure as Reed and Abid have noticed too, is that as people have, depending where they come in their experience, and as they're progressing in their healing journey, they start to let go a lot more, and they're not so focused on the session at all. There's this maturity that comes as you move along your healing journey.
Thank you.
Yeah, I love that. And we do spend a lot of work in the preparatory sessions on managing both expectation and even somewhat on managing disappointment. I saw Deborah's comment in the chat or question, like, what if ketamine doesn't work? How do you manage that? And it reminds me of a psilocybin research study we just did across the street in our research clinic, and where there's a 50% chance of getting placebo, aka niacin. And that's a lot of managing disappointment, because you're going to sit there for 6 hours the same way. And it reminds me of the varieties of the ketamine experience and the different doses we use and how individual it is. So I like what Pamela's saying, and take the same approach of just trusting the process, the unfolding, that whatever comes up is meant to come up in the order that it comes up, and we work with it. Even the disappointment is rich content for therapy. So
that's great. Thank you. Abid?
Yeah, I love the haircut analogy, Pam. That's great. That was a really good visual on that. But I know, just, I guess on the other end, might be, I mean, I agree with everything they're saying. There are times where the content matters a lot, for sure. Like, especially, I guess, like in PTSD, if a patient's able to have some kind of a reframing of the trauma, not everyone can get to that point during a session. But if it does happen, it's anecdotal, but I feel like the benefits seem to last longer, and it just seems to get to the core of the issue better than if it doesn't happen. But agree with everybody that it's not really about the content always with ketamine. If in the case of, like, let's say an ego death situation, and looking at yourself with a new role identity and vantage point, those kind of experiences can be profound and meaningful. A lot of people will make whatever connection they need to make with that experience, even if it's abstract. Like, one time I had a patient saying, she felt she was in a cloud and floating, and it merged with another cloud, but that cloud represented her mother. So she put the meaning to it. And I think ketamine gave her that ability to craft a narrative in her head of why this could be, impactful and beneficial for her, and gave her a new kind of outlook. So.
I
Awesome.
just want to clarify, I completely agree with, I didn't mean, if I came across as not agreeing with the content, I do agree with the content can be very meaningful in some people's cases. And I agree with what Reed said. It's also that disappointment and managing it, because sometimes the message is, I don't deserve to get better, so nothing works for me. And that is rich to deal with a good therapeutic team, whatever comes up with it. But it is managing, because there will be people there's a lot of people that get amazing messages in their ketamine session, and they know exactly what it meant and why it happened, and what they've connected to or let go of, are healed, et cetera, et cetera. And then there's others that, I think we've all seen a patient like this. Nothing happened. Ketamine sucks. You guys have failed me. Complete disaster, complete waste of money. And then you meet one of our team approaches is we meet the collaterals, the family members, the friends, and they're like, oh my God, what a difference. They're smiling, they're laughing, and so that's the wraparound too, is when you have that collateral information, you can bring that back into that therapeutic relationship and go, the world sees you differently. That's rich. That's a rich therapeutic conversation.
Right.
So true. I definitely know content. You're right, Pam. I mean, content does matter, and you're right that a lot of people don't get any content or messages. Did you even put ketamine in the syringe or vial? Can you add more? Like this, almost view it as a failed treatment if they don't hit that dissociation. I usually lean on, like, well, regardless, you might get some level of dissociation, you might not, but either way, ketamine's still doing something. That's when I lean back on the biological benefits of it. But the part of a family member noticing an improvement first, or a caregiver, that's so true. In fact, I think they normally will be, like, when we compare the clinician perspective, the patient's perspective of improvement, the caregiver, and the outcome rating scale. I feel like caregivers are the first ones usually. They notice the small things that are getting better.
Awesome. Yeah, thank you all for these wonderful responses. I love the level of nuance and experience reflected in them. It can definitely, it's wonderful. So next, switching gears a bit, next question, the topic I want to get into is regarding patient screening. A lot of people are interested in ketamine. They're hearing it in the news. It's the closest thing to a psychedelic that's legally available. So what I want to ask is, who is ketamine treatment most suitable for, and who should probably avoid it? And Reed, I want to throw this at you to start.
Sure. Well, As we know, ketamine is a pretty well-known medicine as far as the anesthesia world goes, and is used every day all over the world, and everything from operating rooms to dental offices to backpack medics. So, thankfully it's a safe medicine, but in the psychiatric uses, we do have special things to keep track of, and a lot of attention to be paid to someone's mental health history and risk factors. So that brings up one we commonly hear about is a personal history of psychosis or mania presents a risk, because ketamine or other psychedelic type medicines can exacerbate or unearth something like that. It used to be that studies would exclude even a family history of psychosis, like a first degree relative, but that's been loosening, and it's still an open research question and a much needed debate of, like, can ketamine be helpful for these individuals? And I'm of the belief that yeah, it may be, but we need to pay extra careful attention for certain conditions for sure. But you also brought up a good point in the question of people sometimes are seeking it out just for the experience. So we make sure to screen carefully for someone's substance abuse history and current substance uses, their intentions, and we're not going to give ketamine to someone unless they meet criteria for a DSM-5 diagnosis clearly. But the ones, like many others that we most often give it for, are treatment-resistant depression. We're not going to turn to ketamine the first thing someone ever does for the first sign of depression ever in their lifetime. PTSD with the added therapeutic support and knowledge that sometimes you might feel worse before you feel better, and it might stir some things up, and we need to have the team in place for that. And then all the other areas where there's growing data to support it, like in OCD, and I have a particular focus on an interest in eating disorders, where we've done some research and do some clinical work. And we just even completed a pilot program for healthcare workers with burnout and stress from the pandemic, using ketamine in a group format over 6 weeks, 3 dosing sessions, a bunch of therapy. And in looking at the data, it's been really exciting so far. And the anecdotes that came out of that are just so inspiring. So I think we're just scratching the surface, and we need to approach it cautiously too.
Thank you for that. Pam and Navid, did you want to add to that in any way?
I mean, I would agree with everything Reed said. It's not much to add. I think on the substance use part, that's important. So for me, it's like, obviously ketamine helps substance use disorders, but so as long as it's being screened for, I mean, we do baseline toxicology on every, ketamine patient, but then for substance use disorder patients, then it's about, really setting expectations of how we're going to use ketamine to help improve the substance use disorder. So it's a kind of it's a balancing act. You don't want them to rely. We don't see any issues in a medical setting providing, ketamine for substance use disorders. But I think if it's something like somebody's getting prescriptions for it at home and nobody's screened for a substance use disorder and nobody's addressing those psychological thought patterns that are being reinforced with another medicine at home, and there's no tracking of it, that is a recipe for disaster. And for psychosis and mania, I mean, we know for sure bipolar disorder, if it's the depressed phase, yeah, it can help great, but again, needs to be really monitored closely, because when we have seen it really throw somebody into the other end of the spectrum. So.
Yeah, I agree with all of that. Roots to Thrive is only group therapy. And so part of our screening is to make sure that people can attend and do that group therapy, and that they're comfortable with the group process, and that the fact that they will actually be having their ketamine session in group and sharing and integrating in group. And so that is part of our screening process, as well as in addition to the medical screening. And we actually have a number of addiction physicians on our team now. And it's because we're seeing substance use drop. So we look at substance use as a symptom, not the issue. We don't give that a diagnosis. We say that's a symptom of a pain, of a trauma, of something, and we really try to get to that and work on that. And we see substance use dropping dramatically in our program with even before the first ketamine session. So it speaks a little bit to the power of groups and community and people coming together and being heard and sharing. We've had people, especially with alcohol use, talk about that their alcohol use drops precipitously even before the ketamine sessions. And the other thing, the eating disorder stuff and disordered eating generally, I mean, that's one of our biggest substance use issues in society is disordered eating and using food as a drug and as a soothing drug. And we see that change very, very quickly and get replaced by nature. Like that's what we see is people, I'm outside walking now. I'm out in the forest, I'm getting outside. And so I think, you know, it's choosing people that work really well in group and recognizing that all these other symptoms are just really at the seed that we want to get at with them.
Awesome. Thank you so much. So another related question, you guys partially answered it, but I think particularly earlier you mentioned how we need to really tune our approach to the patient and what they're ready for and what they're able to handle. So just broadly speaking, what would you say are the primary risks associated with ketamine? What kind of adverse events happen that say if somebody's given too much or they're caught off guard in some way, or you know, it's not perfectly tuned to them as much as it could be? Like, what are the risks that people might be facing by taking this treatment?
I could start off. You know, there are of course the physiologic risks of increased heart rate and blood pressure during the session. The reasons why we monitor and screen for, you know, conditions with increased arteriovenous pressure beforehand or unstable hypertension, things like that. But you know, from a mental health standpoint, psychiatric risk standpoint, you know, I think we need to always be aware of the suicide risk in our clients and just make sure there is, you know, all the support needed and the screening and the checks and balances and touch points with follow-up based on the individual's condition and needs and history. So I think that there are certain conditions where we're not going to start ketamine unless there's you know, all these components in place. And there's also the risk of a difficult experience coming up, and is the individual well equipped to deal with that? Do they have not only a ride home, but what happens when they get home? And you know, will they follow up? And I think it's worth pointing out that, just like we've been saying, ketamine can be a potent catalyst for addiction treatment work, but it also is a drug of abuse in most parts of the world, and there is a risk potential of unchecked ketamine use. And I certainly believe that we need to be extra careful with you know, frequency, and especially of take-home ketamine, that you know, the frequency and the follow-up visits are so important there, along with the underlying conditions.
Thank you.
Yeah, not much to add. I think pretty much all covered. Probably the only other one to really, I think that I have some relevance in, I guess, how I practice is just tracking cognition. You know, we usually do baseline cognitive testing at baseline, and then especially when somebody's down, you know, down the line and they've been maintaining a while, depends how much they get, how frequently they get it. We'll repeat testing and make sure. I mean, it's super rare that in this context where I've seen it become an issue, but a couple times it has, where we've seen changes on their cognitive testing. Nothing that a little break from it can't like really help resolve, but just one of those long-term risks, I think, to keeping track of.
I agree with both of what you've said, and the additional part is, you know, we don't ever think of that there's a bad trip. You know, we again, this is part of your preparation. You say you may have a challenging session, you may have a really challenging session, and we're going to integrate it. You're going to have a conversation about that. The nice thing too about the group, again, is the group is also witnessing the experiences too. And that's really, really powerful. You know, if somebody had a really horrific session, and even though we use noise canceling headphones and eye shades and the music's in the room, you know, they can hear somebody having a challenging experience, and the witnessing of them saying something like, you know, I could really hear you wailing and my heart really went out to you because I knew you were really working on something big. Like something like that. Like it sounds like just, oh, you know, if you've never been in a session like that, you may just blow that off, but it is deeply profound in that person's healing to have been heard in their suffering and in their challenging experience, and it changes everything. And so, you know, there's a lot of power in these medicines, and we don't do any take-home stuff, medicines. I think people have to be very careful if you are sending medicines home. The other challenge we've had is we know that we have to publish on the data, like Reed's doing a lot of work, we're doing a lot of work. We know we have to get this data out there, and that the challenges is measuring fatigue for our patients. You know, people with PTSD, they hate doing assessments. They're so tired of being asked questions over and over and over. So we're trying to find that balance to measure at the beginning of the program, through the program, and then in the 6-12 months after, to see what those results are. But it's challenging to keep asking people to be assessed over and over and over.
Thank you. So next I want to move to the important topic of accessibility, because sure, these treatments exist and they can be offered and really impactful for patients, but how accessible is it to the ordinary person, or especially underrepresented populations? And particularly, this is a financial question. So given that ketamine is, it's approved, FDA approved, but as an anesthetic, so all uses for mental health are off-label, meaning that insurance providers usually don't cover it. So the question I want to ask is, how can we make ketamine more affordable for patients? And Pam, do you want to start us off with that one?
Well, I'll be answering from the Canadian perspective because I'm a Canadian physician. Our program is in Canada. You're right, it's not covered. Our program is private pay, but we're making inroads. We're really publishing as much as we can on our program. I meet like dozens of hours with our like WorkSafe, like workers' compensation, and helping them bring them up the learning curve of the data and the emerging data. And so we now have some firefighters that have been covered under workers' compensation. We've had some paramedics covered. We have a police officer going through that will be covered. And I think, that it will speak for itself, and they will see the cost savings of that. Our program is generally, we made our program a nonprofit, and we're moving into a charitable society within the next year, exactly for this, so that we have a lot of scholarships. We bend over backwards to find money for people that can't afford to be in our program. We apply to foundations, we apply to grants, we take donations, and then we keep it as low as possible. So our program runs about $6,000 for the 12-week program and the 3 ketamine sessions. But it breaks our heart. Like, this cannot be a have and have not situation. This cannot be, if you can afford it, you get treatment, and if you don't get it. So we're really working on partnering on those levels and publishing, and making the argument that this should be covered.
Thank you.
I can chime in on a couple things we're doing. As I mentioned, we have this model of in addition to the private individual sessions that cost a little more, we have this shared monitoring set up in order to keep prices really affordable for traditional like IM or IV ketamine work. But for years, we've been battling with insurance companies and to try and get coverage. And at first it felt like, it felt like we weren't getting anywhere, just chipping away or banging our heads against this wall. But then it started to crack, and we got some prior authorization for single case agreements with ketamine. And then I think it was last November at Novamind, we announced ketamine insurance coverage with 4 different payers for ketamine. And now, since then, we've gotten more and more on board, and at least it's early, and a small percentage of the ketamine work we do, but we've gotten dozens and dozens of ketamine sessions covered by insurance. They'll often specify it needs to be IV, it needs to be done this way, because they're going to lean on available evidence. But that's that provides me with some hope. And then when S-ketamine came out, Spravato as a nasal spray treatment in 2019 for TRD, we adopted it, and we've given it 10,000 doses since, every single one of them covered by insurance. And we leverage patient assistance programs where Janssen will give like somewhere above $7,000 towards the individual's copay for the medicine. So if their insurance covers any of it, then we can leverage this for the rest. And then they have $5 as a copay. It's different than IV ketamine. That's a separate question, but I believe there's a lot we can individually and collectively do to keep working on this accessibility challenge.
Yeah, I definitely agree with all of that. I mean, Spravato, for me, that's why I always want to offer it. And it really comes down to access, because ultimately one of the quickest ways at least in the medical model setting, is to have insurance coverage. I mean, that's the way to get the most access the fastest, especially if we can get to the point of getting state Medicaid programs to start covering it. Then you're really casting a much wider kind of like net to allow people to get this treatment. How do we even, I mean, maybe I'll ask Reed after this on how he got it, but that's the exact path we're following too, is trying to get the local insurance carrier plans to start covering it. I've had, like Pam was saying, success with workers' comp cases, EAPs, like single case agreements. We've gotten coverage over the years, and it's getting easier and easier every time. I mean, we know Blue Cross Blue Shield Massachusetts and Vermont they have medical policies already released for, at least for IV formulation for ketamine, and covering it for TRD. And the only other ones I know of are the ones that Reed was talking about in Utah. So, but the way to really move that needle from the route that we're trying to take is outcome data collection, and being able to, make a value proposition deck. And the more you're able to show cost savings for an insurance carrier, the better the odds are of getting coverage for it, especially at an enterprise level. So I think that's important, that, we always keep collecting outcome data, and we keep, aggregating it and keep pushing it forward, because that's the language that needs to be spoken for them to understand that this is something that needs to be covered. So efficacy and the level of data out there is one part of it, and then the other part is, how does it help cost savings? If you can show that I've avoided one ER visit, one hospital stay, I mean, that pretty much one stay will break their budget compared to many therapy sessions or IV ketamine sessions or IM ketamine sessions. So, but definitely, I think trying to work with your local plan is important. So I'd probably throw that question back to Reed. How did he do it at Novamind with their local carriers?
So you mentioned Spravato and, well, outcome data. Yes, we've had to provide some of these payers with unpublished internal data and references from the literature to justify to give rationale for why we want to do this. But what I've seen as the golden opportunity, or the open door to the conversation, is if someone doesn't cover S-ketamine on their panel, you could go in and say, okay, how about ketamine instead? This is why. And that's a great starting point.
Great. Yeah, thank you for the responses. So I guess this was kind of answered by Abid. So the answer would be more data is needed. Even though there's many clinical trials, it seems that insurance providers want outcome data from actual real world clinics. So this just goes to what Pam was saying earlier, is like clinics need to make the most of the patients they're serving and create data that can be used for insurance and for more broadly seeing the actual efficacy of the treatments given at a given clinic, and also just contribute to our knowledge more generally. It's so important. And yeah, it kind of boggles my mind that there's hundreds of ketamine clinics in the US, and now they're sprouting up in Canada, yet still no insurance coverage. And I'd imagine if everyone was collecting data from the get-go, we'd have amassed large quantities of data that could be used to justify and make these value propositions, as you said, Abid, towards providers. So if anybody listening to this has a clinic and is not collecting data, you got to get on that. It's for the whole cause, as well as your own benefit and interest, and not even mentioning the patients.
The other thing we're doing here is we're actually actively trying to track down a really good health economist to run the numbers on what the cost savings are. You know, the MAPS MDMA trial did their cost savings, and it's remarkable. And you know, the cost savings, the quality of life savings, et cetera, et cetera. So we know at a minimum for every one person that goes through our program, we have a lot of nurses, a lot of doctors that go through our program. I mean, if at a minimum, it's a $30,000 savings. The apps and if you look at putting a firefighter back to work, that's $100,000 savings. It's even if you don't care, if the insurance don't care about people, if they just care about money, it's a huge cost savings. I mean, we care about people. That's why we're doing this. But either way, it's a win. People get better and money is saved.
Certainly, certainly. Great. So one last topic here. Then we have one question. I'm just going to ask to the panel. So last question is around ethics and regulatory oversight. So of course, with tons of ketamine clinics sprouting up, the pertinent question is, what needs to be done to ensure ketamine treatments are marketed and also administered in an ethical manner? And like, what are examples of practices you see as unethical, which might be commonly or sometimes committed by different clinics? So I don't know if anybody wants to jump in on that first.
Well, I'll go, I guess. I think that's, so for me, some unethical practices would be, you know, giving basically, you know, kind of not a realistic, you know, expectations for patients, kind of framing it like only showing them the good side. This is, you know, miracle cure, or not telling them, you know, what exactly they're administering and how they're administering it. I mean, sometimes somebody says, you know, we have our special blend of ingredients that we administer, you know, things like that. It's just not, there's not enough transparency. So, I mean, really following those guidelines is important. I also am not a fan of, you know, the practice of, you know, doing, let's say whatever, and let's say it's IV treatment course, and then just kind of writing for home ketamine prescriptions for ongoing maintenance without, but I mean, for me, my mind's not there yet, just at all for that. I don't just think there needs to be more development of what the, you know, treatment standard should be. But I mean, that is a practice out there for kind of ongoing, unmonitored, you know, self-administered ketamine. That to me is, you know, not real. We're not at the point where we can do anything like that. So for me, it's really important that we just are transparent. We give a very good informed consent process, and screening has to be a more robust of a process. It should not mean that you can just walk in and fill a PHQ-9, and based on your score, that's what determines whether you get it, because that is a standard at a lot of places. It really is. The more, you know, the more robust screening process you have, yeah, you may have more times where a patient's turned away for this treatment at that time, and it's not the right approach for them. That doesn't align always with profit incentives. So especially in a model where, you know, unfortunately it's not insurance covered broadly yet, but there's also the concept of trying to align with value-based approach, which is where healthcare coverage is heading towards, at least in the United States model. And that means patient gets better, you're reimbursed better, versus the more you order, the more services you provide. So it's just about alignment on that as well. Like Pam said, that putting, you know, trying to put ourselves out of business, that's a great way to approach it.
Thank you for that. Pam, Reed, did you want to add anything to that?
Sure, I can maybe just share some resources, ones we like to point to in terms of ethics and ethical guidelines, because we'll spend a lot of time on this with new clinicians beginning this work in ketamine-assisted psychotherapy, because while they're similar to the regular work we do in psychotherapy and med management, there's some unique considerations with the non-ordinary state and the vulnerabilities and all the other dynamic factors at play. So There's a great article by Raquel Bennett and Wesley Ryan from Korea that gives ethical guidelines for ketamine clinicians. I'll put that in the chat. And then the MAPS MDMA Assisted Psychotherapy Code of Ethics is another one we'll have as required reading and deep discussion that goes over everything from boundaries to use of touch. Like that's an important one in ketamine assisted psychotherapy work, to make sure there's consent on all these fronts, and also how to approach diversity and confidentiality and transparency and your own disclosures and things like that. It's a very important discussion, but I think these articles do a great job.
I would jump in on this too, is around the ethics. It's really speaks to, it's a challenge. Again, being Canadian, we have universal health care, but the profit motive is part of the ethics. And why are you even doing this? There are always going to be economic opportunists. I have no issue with people making money or being paid well, but why are you going into this? And are you doing a good job? Are you really truly providing a high quality service? And again, to quote Raquel Bennett, who's a wonderful elder and expert in this area, she said many years ago to me, is that there's going to be 5-star therapy, like people who do it really well, really good ethical standards, really good intakes, really good therapy, really good follow-up. And there's going to be McDonald's drive-through. And fundamentally, all of us as professionals have to decide, where is our integrity? At what level do we want to operate? Do we want to be the 5-star, the high integrity beacon of good standards of practice? Or do we want to be, the drive-through fast food provider? And we all have to make those decisions.
Awesome. Yes, wonderful points. Thank you for those answers. We're coming up on time. We have 3 minutes left. There's one question in the Q&A box here. I'll just ask it to the panel, and you guys can let us know your thoughts. So the question is, what are your thoughts on ketamine becoming a more first-line medication versus the standard SSRIs, etc.? Why isn't ketamine a first-line treatment?
Just a quick thought from my end is, I am all for trying to figure out ways of working on depression that don't involve taking a daily pill and getting more at the root underlying cause. And I would just highlight the need to do a course of psychotherapy without some of these risks involved in even ketamine. We talk about its safety and its risks. One thing to point out with ketamine is, while it's a rapid antidepressant, its effects are temporary. So what next? It might be enough to pull someone out of an episode. You might need serial infusions. That might be enough. It might not. And then what happens? So that's one of the concerns and reasons why it hasn't been adopted as such. And certainly more research is needed. And there may be potential there.
It'll also be hard to have it as a frontline, because we're going to need a large clinical trial, randomized clinical trial. And where's the profit in that? There's not. It's generic. It's $50 for a vial. It's $2. The equivalent Spravato dose is $2 from the generic. So who's going to do the trial? That's why it is so imperative that us little clinics, little programs publish and get it out there.
I think when I started, 5 years ago, at that point, it just felt that, my criteria, I would say, okay, you have to have the TRD depression. That means at that point, I was defining it as like 4 failed antidepressant, covering 2 different antidepressant classes and trial psychotherapy. Then I think when Spravato's label came out, and they kind of defined it as 2 failed med trials. So it was actually, I think it was looser of criteria than I was expecting at that point, which, in the beginning, there's a little discomfort when you just start with this. And then with time, we're thousands of treatments in now, it feels like we feel a lot more comfortable with it. And we realize that it can, I think, be used earlier in the algorithm of so should it be first line or not? I agree with Reed. We might need some research. There's some potential there. But I know for me now, I'm at that point where I will use it as a first line if somebody has severe symptomology, and as a temporary first line. And then if we can get to the point that after the induction course, if we're maintaining, but if it's maintaining like very irregularly, you know, every 3-4 months or something, then if we're going to do a risk profile on SSRI daily usage versus every 3 months a low dose ketamine treatment, you know, you can make the argument that ketamine might have a better like risk profile than SSRI. So I think with time, it's a dynamic belief on my part. My view keeps changing with time, with data, with more experience, and it keeps moving earlier in the algorithm. But I don't think it can ever be where it's just the first line and without any extra wraparound services, any other support, if there's not a psychotherapy program with it, so you can then do the first line treatment of ketamine, use psychotherapy and behavioral modification and changes so you don't need to maintain on it, then I think that'll change the entire discussion where we're looking at like remission and not just response and maintenance, like kind of the old standard that it has been for all these decades with SSRIs.
Mhm. Awesome, thank you. We're at time here. Do any of you want to say any last words before we close this off? 3, 2, 1. Okay, no, yeah. So I want to thank you again for taking time out of your busy schedules to be on here today. This is a really great discussion. I'm sure it will be very valuable for anybody interested in the space to watch later on. And thank you to our attendees as well. And yeah, hope you all have a great day.
Thank you.
Yeah, I'd like to
Yeah.
jump in again and say thank you all for being a part of this. Thank you, Manish, for doing such a wonderful job moderating, and to all our amazing panelists, Abid, Pamela, and Reed, for your directness and honesty and heartfelt information that you gave over. We can really see how much you care and all the work that you're doing. And also the attendees, because, you know, to come to this and put in the time because people want to learn more from you is just a great step forward in the direction everyone's trying to achieve. So thank you all again. Have a wonderful day, and we'll see you all soon. Thanks, everyone.